Everyone, welcome to the final session of the day. All right, so let's get started. My name is Nell Griffin. I'm from Telegen, and I will be the moderator for this session. Allow me to introduce our speaker, Dr. Emily Drwiega. Now, Dr. Drwiega is a visiting clinical assistant professor of pharmacy practices at the University of Illinois at Chicago and a clinical pharmacist at UI Health in Chicago. She graduated from pharmacy school at Butler University in Indianapolis, Indiana, and has completed 2 years of residency, including an infectious diseases second-year residency at Grady Hospital in Atlanta, Georgia. Prior to her current role, she also completed an infectious diseases pharmacy fellowship at the University of Illinois at Chicago. So it is my honor to turn it over to Dr. Emily, and she'll tell you more about herself.
Good afternoon. Thanks for having me. I do realize that I am what stands between you and home and dinner, but hopefully this will be pretty painless. Today we're going to talk about Candida auris. Just out of curiosity myself, can I get a show of hands of who has experienced, treated, has patients that are colonized in their institution, patients that are, okay, some, okay, great. So we're gonna go back to the beginning of Candida auris, and we'll work through kind of to present throughout this presentation. I have nothing to disclose. And then regarding objectives, hopefully through the historical chat today, you'll get some of the epidemiology and emergence and spread. We'll talk about the challenges associated with both diagnosing and treating Candida auris, and then some of the strategies for infection control. So I gave this, or a version of this talk, I guess, last summer, and it was to a joint meeting of Illinois and Missouri pharmacists. My Illinois pharmacists were able to raise their hand and say, yep, we've heard of this. And then Missouri had not heard of it. And I looked, they had 1 or 2 cases prior to that presentation. So I think now in Illinois, we are greatly familiar with this. And by the show of hands, it seems like we have some familiarity. But I think this has made its way to the lay press as well. And so being able to just have the conversation when patients ask about this sort of thing, I think is important too. I think that the Last of Us, that Fungus zombie TV show a couple of years ago, I think that also just kind of brought new attention to some of our fungus that we are dealing with. So this is not zombie thing. So Candida auris, it is an emerging yeast capable of causing invasive infection. It was in March 2023 that the CDC issued a warning, including it in their urgent antimicrobial resistance threat due to the rapid spread. Candida auris mostly affects patients with underlying conditions, severe medical conditions, those that have complicated medical care or have invasive medical devices. In general, this is not considered a risk for healthy individuals. Obviously, there are cases that occur, but for the most part, uncommon. So taking it back to the beginning, which is really not that long ago, Candida auris was identified in Japan from an external ear canal, hence its name auris, that is the Latin for ear. The first identified case was in 2009. After further review of Candida species that were never identified or not fully identified, it was actually found that the earliest known strain was in 1996 in South Korea. In that time, from 2009 to now, and even from 1996 moving forward, we attribute this spread or the rapidness of the spread in part to climate change. It is hypothesized that the antifungal overuse or the thermal adaptation with climate change has led to some of this transmission. The organism has become much more thermotolerant than it previously was, which has contributed to that spread, the ability for infection due to this pathogen in humans. Candida auris can be spread in many different ways. So the first being contaminated surfaces and equipment. So this is one challenge with regards to any tools that you're using, your blood pressure cuffs, your pulse oximeters, anything transferred room to room or patient to patient, that could be a contaminated surface. We also know that Candida auris persists for a long time on these surfaces. There are studies looking at plastic, glass, steel, cotton, all these different things, and really finding that it can last for 2 to 3 weeks in many of these cases. It does also persist on human skin. It does have a unique tropism to survive on skin. And even in humans then, or on human skin, it can persist for prolonged periods of time. This can lead to spread via individuals who are colonized or infected with Candida auris via contact to contact. Some risk factors for individuals who are at increased risk of developing Candida auris infection are individuals with indwelling medical devices, anything from feeding tubes, central lines, urinary catheters, any sort of invasive medical devices are often, or they are a great pathway for Candida auris to go from colonization into the body and become infectious. Mechanical ventilation, prior antibiotics and antifungal. There has been more and more data suggesting that these patients are co-infected with multi-drug resistant organisms, or that multi-drug resistant organisms preceded this infection for patients. Those that are immunocompromised are at increased risk, and then frequent or long healthcare stays. And this includes any, step of the healthcare system. This includes hospitals. This includes all of these long-term care, skilled nursing facilities, all of those as well. So I told you we talk a little bit of history. So in the United States, you can see here in this graph, the number of clinical cases are on the left. We've got the years on the right. And this is specifically talking about clinical cases. So those are patients who tested positive, were deemed to have infection, and had signs and symptoms related to their infection. Candida auris was made nationally notifiable in 2018, so the data prior to that may be a little bit underestimated, but regardless, you can see this huge jump in the last few years. A 60% increase from 2019 to 2020, and then nearly double from 2020 to 2021. Part of this is believed to be due to COVID-19 hospital-acquired risk factors, and leading to additional clinical illness in these patients. In 2022 alone, this is the most up-to-date data that we have at this point from the Center for Disease Control. But in 22, there were 2,377 clinical cases and more than 5,000 screening cases of Candida auris in the United States. States have been voluntarily able to submit or to notify for samples since 2013, but the data back then is very limited due to cases, but probably also due to identification challenges. To break it down a little bit further, in this map, the darker the red, the greater the number of clinical cases. Again, this is just clinical cases, not screening cases. And this data they actually share with us through the end of 2023 from the CDC. So as you can tell, Illinois, we are one of 2 states with the darkest red color, us and New York. I can tell you, this map alone is out of date. Washington State came out a couple months ago to say they had their first clinical cases. So I know that, there's even more than when this was last reported in 2023 by the CDC. You can also see from this map where I joked about Missouri and Illinois, you can see the stark difference here of the number of clinical cases. And so I think it's important. This is continuing to spread. I wish I had time to show you the map over time because it's pretty remarkable to see how each state has gotten more and more cases over time. So to zoom in on Illinois a little bit specifically, you can also continue to see that trend of increasing cases, particularly 2018 and forward. In the last 12 months that were documented, we had over 880 clinical cases in Illinois in general, and then over 200 in the last 12 months. All right, history lesson over. Let's get to the good stuff. So diagnosis, treatment, and prevention are three big challenges with Candida auris. So we're going to go through each one of those, and I'll kind of share some recommendations as well as some of the things that we've identified at my institution at University of Illinois Chicago. We'll start with diagnosis. Diagnosing Candida auris is challenging. It's better than it was. We now have approved testing. More databases are able to identify Candida auris, which is helpful. But in general, it can be misidentified by our typical phenotypic methods. And there really are no good characteristics to help easily distinguish Candida auris from some of the other Candida species. MALDI-TOF is the recommended, believed to be the most accurate way to diagnose specifically Candida auris. But of course, regardless of what device you're using, knowing whether that is capable, the reference library from that device is capable of identifying Candida auris. I know years ago, our diagnostics would tell us it was Candida, but like couldn't go beyond that. So it's getting better. We are, some of the technology is improving to be able to identify Candida auris. PCR-based testing is an option, obviously, but then also isolation on very specific broth can help with this. But of course, then you have to suspect this. Isolates can be sent to the CDC lab to be identified, as well as for resistance testing if your institution is not able to do that. The point here, one of the problems here is that all of these things contribute to delayed or incomplete identification, inability to test susceptibilities. So that in itself is a big change. For those who work in a hospital or are familiar, in many cases, we're going to empirically start any kind of Candida, and we'll talk treatment in a minute. But fortunately, that is often the first choice, or that is the first choice for this organism. So we're able to treat even before we know what it is in many cases. We'll switch gears into treatment. So first line treatment is echinocandins. I just gave that spoiler alert. There have been no randomized controlled trials for Candida auris treatment. And I don't know that we're really going to get something as robust as we would like. That being said, traditional echinocandins, IV only, generally well tolerated. And this is what many patients are being empirically treated with once they have identified a fungal infection, even for a Candida species, until we know that it's Candida auris. The second line option is liposomal amphotericin B. This is for adults. This treatment algorithm is for adults, but this is generally recommended to switch to if they are unresponsive to the echinocandin, if they are not clearing blood cultures with the echinocandin, or in some cases, there has been development of resistance while on treatment. So in all of those cases, a liposomal amphotericin B would be recommended as next line. Finally, in the instance of a pan-resistant infection, a isolate that's not responding to first or second line therapy, there is some data supporting the use of combination treatment or treatment with some of the investigational drugs, including flucytosine, rezafungin, and we'll get to those in a sec, but possible options for combination therapy. This is, to me, is what drew my interest and my attention to Candida auris. These are breakpoints that are unofficial. They are not established. There is no, at this point, clinical correlation to these breakpoints. It should not be considered as definitive breakpoints for resistance. But right now, this is what we have from the CDC to go off of. I also want to make note that this is the resistance pattern for the US as a whole. And I'll tell you a little bit more about what we were seeing at our institution. But from this chart, as you can see, fluconazole is estimated 90% resistance. Echinocandins, which as I mentioned are our first line, less than 2% resistance. So this is why even starting empirically, an echinocandin would be hopefully successful for your patients. 90% of fluconazole really stuck with me, and I guess that's why I have become so interested in this organism. Not something I would normally think of as being a antifungal that other organisms are routinely resistant to. A key factor in the emergence of this antifungal resistance for Candida auris is considered to be antifungal use. Azoles are used in agriculture. They are used for prophylaxis. They are used for a variety of reasons. And so that is the theory as to why there is increasing or already starting with high resistance to azoles. I want to briefly introduce these three newer agents. The first one being ibrexafungerp. This is approved as of a couple years ago for vulvovaginal candidiasis. They specifically had a trial called the CARES trial, and that was looking at safety, efficacy, and tolerability for patients with candidiasis, including candidemia, including Candida auris. This was studied as an IV therapy. The trial has been completed. There's some minimal results on clinicaltrials.gov, but I am not aware of these results yet. So if somebody has already found them, please share those with me. Rezafungin is the second newly approved agent. It was approved for the treatment of candidemia and invasive candidiasis in adults, I'm sorry. It is an IV weekly option. It's a novel echinocandin. The RESTORE trial for this study, it allowed for Candida auris, but there were very few cases that were included, but it has demonstrated in vitro activity against Candida auris. So maybe this could be an option as well. I think we're going to have more data on that soon. And then for fosmanogepix, this is both oral and IV. This is still recruiting for phase 3 trials. This is not FDA approved at this time. It is fast track status though. And when I had to have these slides together a couple of days ago, the phase 3 trial said it was about to start on Tuesday. So hopefully we'll have some information in the coming years. I don't want to forget about general management considerations. You want to treat this similar to how you would treat many other candidemia infections or candidiasis, regardless of how you'd want to treat them to treat and reduce further recurrences. So the 2016 IDSA guidelines is a place to start for just general management of candidemia. Between that and the CDC, these are some of the recommendations they share, and I wholeheartedly agree with in terms of consulting an ID specialist if possible, repeating blood cultures until cleared, establishing source control if we are able to, and then implementing infection control strategies during and after treatment. I think all of these things we may be familiar with already doing for candidemia infections or for Candida auris. And so that's why I agree that they should apply to Candida auris as well. I do want to quickly talk about non-sterile body sites. This is a question that I feel has come up frequently. And so from the CDC, they recommend that treatment is not needed without evidence of signs of infection, which is a different take than what some articles previously published have suggested. And so part of that I attribute to maybe the articles from a couple of years ago. This was still new enough that they were taking extra precautions or treating perhaps asymptomatic infections for that reason. But I think the other thing, and particularly looking at those past articles, what is the risk of invasive disease to colonized patients? And I think that's something that we don't have a great answer for. I'll share some data later, but something to consider, risk versus reward of treating a non-sterile body site or a non-invasive body site infection. So I'm going to pause here and talk briefly about our experience at UIC. One of our pharmacy fellows took on this project. It was presented as an abstract and poster at ECMID back in April. And it's a small study, but I think it gives you an idea of kind of what we're seeing. And I'll try to point out some of those inconsistencies. So this was a retrospective chart review. It included hospitalized adults that had a positive blood culture for Candida auris. And what we were looking at through this study was all-cause crude mortality in patients with Candida auris fungemia, as well as additional outcomes including antifungal susceptibilities, readmission rate within 60 days after their discharge. Some baseline demographics, nearly half were male, median age of 56. You can see that nearly half of the patients that had fungemia had a diagnosis of a chronic disease condition. This could be anything from CKD, cardiovascular disease, diabetes. This was a pretty comprehensive list. You'll also notice that more than half were admitted from a healthcare facility. This could be a long-term acute care, nursing home, skilled nursing facility, rehab facility. All of those are encompassed there. Again, of the 24 patients included, they had a length of inpatient stay of 40 days. I think this is important to note as I've shared the risk factors of hospital exposure and lines and mechanical ventilation, all of those things. I don't think it's too surprising to see that our length of stay is 40 days. I also want to point out that the time from the admission to that positive culture is over 3 weeks. So again, these are patients who are in the hospital for prolonged periods of time in our experience. The other thing I want to point out is the days from index culture to discharge. So these patients develop a positive culture, positive blood culture, and they are still in the institution for about 3 weeks as our median. So these are very long hospital stays. Patients are receiving IV treatment in the hospital. Something like amphotericin can get challenging to do OPAT for. And so these are long stays for most of these patients. For our 24 patients at UIC that had fungemia due to Candida auris, you can see that our rate of in-hospital death or discharge to hospice was a third, 33.3%. So a third of our patients, 33% for our crude mortality rate. I will point out here too that as I've talked about all of these risk factors, it is very unclear which of them may have caused, the patient death. I think we know that these are complicated patients. We know that they have other things going on. And so while I say that a third of our patients died before or were discharged to hospice, it's hard to say what the cause there was. So I do want to be mindful of that. 30% is about consistent where some of the other literature has reported. Again, very small study that we've done, but it is fairly consistent. But we all have that challenge of cause of mortality. And then for those 16 individuals who survived beyond their discharge, half of them had to be readmitted within 60 days. And again, this is not specific for a return due to Candida auris. This was all cause readmission within 60 days. This is probably the most interesting thing and the reason I really wanted to share this with you guys. So these are our isolates from those 24 cases. Again, I listed in the top row those tentative, non-established susceptibility breakpoints that we know there's no correlation yet in terms of microbiologic breakpoints and clinical outcomes. But I wanted to put those there for you. But then our number of resistant isolates in that bottom line. So out of 24 isolates, we had 2 that demonstrated any sort of resistance. If you recall, a couple of slides ago, we said that across the country, 90% are azole resistant, 30% or about 30% amphotericin resistant, and then less than 2% echinocandin resistant. So this was shocking to me, and this is really what kind of drew me in with regards to this project, that our institution had such lower susceptibilities than everything I was reading, everything I was looking at. The IDPH actually posted or published a document a couple of years ago now, kind of explaining this phenomenon, because it seemed that other institutions in our area were sharing some of this pattern of lack of resistance. They also tried to look at different clades around the different parts of the country to see if they could be connected, to see if they could be traced. But this is something that is unique that we're seeing in the Chicago area. I'm not saying we should be using fluconazole for this by any means, but I think it's important to be aware of and make sure that we are identifying susceptibilities for these patients. All of our patients received micafungin as targeted antifungal therapy, so they did all receive an echinocandin following susceptibility testing. We did not switch any of them to fluconazole. So again, I know it's a small study, but I think some of the takeaways from this are that, half of all of our patients were admitted from an acute healthcare facility. Many of them had chronic conditions, as we talked about, those being risk factors, and we definitely saw that in this study. We observed a crude mortality rate of 33.3% in patients with Candida auris fungemia. And then among patients who survived, there was a 50% chance for readmission within 60 days. In this small study, we did not look at additional outcomes of invasive Candida auris. We did not go deeper than that thus far. Additionally, the majority of our institutional isolates were susceptible, as I mentioned, to all 3 classes, and only 2 had elevated MICs to fluconazole. We'll switch gears and we'll talk a little bit of prevention. I already showed you this slide, but just to refresh, as we're now talking infection prevention, this can be transmitted contact through contaminated surfaces or equipment from person to person and individuals who are colonized. There are reports of outbreaks for these reasons, and Candida auris can colonize non-sterile body sites. That being said, there are a lot of strategies that can be used to help the prevention and help decrease the spread of Candida auris. First and foremost being that contact precautions should be utilized. These are often similar, the recommendations are similar to multi-drug resistant precautions. So if you're familiar with those, they are recommending a similar enhanced precaution for anybody with colonization or infection. Environmental disinfection is also a challenge with Candida auris. Many of our hospital commonly used disinfectants are not capable of eradicating Candida auris. Through the EPA, and I will share the specific list with you guys later, but through the Environmental Protection Agency, they do have a list of particular disinfectants that can be used. Just because it says antifungal does not mean it includes Candida auris. I think that's an important thing to note too. And quaternary ammonia compounds, which are another commonly used disinfectant, do not work here. There are some recommendations regarding patient placement, but I think this really varies based on institution, whether we're discussing a nursing facility or a hospital or the ICU versus the general hospital, in how we can place patients, whether it's appropriate to have designated locations for colonized patients. So equipment from that standpoint could be less of a challenge, or nursing passing from one room to the other. There is some guidance on the CDC about sharing patient rooms for individuals with have colonization, those sorts of things. So something to be mindful from a infection prevention standpoint. There are also, we are able, fortunately, to screen for colonization for individuals who are at high risk. That is a swab typically done to axilla and groin that can identify Candida auris in individuals who may be colonized. Some of the strategies in preventing spread are ensuring that communication occurs between facilities as a patient is transferred in or out, discussing, if there are those procedures put in place at the hospital for swabbing, at the facility for particular room or equipment, those sorts of things can be transferred. As I mentioned, it can persist on all sorts of equipment in the room. And actually one study has shown that not only were like the bed rails and the bed tables have identified as having Candida auris, but things like the windowsill much further away from the patient has even demonstrated. So could be, lots of reasons for that. But I just want to mention that as it might not be something we think about normally. As I already mentioned, the Environmental Protection Agency has a registered list for disinfectants currently approved for use with Candida auris or for the treatment of Candida auris. As I mentioned, products with general fungicidal claims may not work for Candida auris. So it's important to make sure you are aware if that product would be effective or not. There are also contact time instructions for products on those lists that may be different than our standard cleaning and disinfectant current procedures. So I've talked a little bit about screening, but this is definitely one way that hopefully we can identify individuals who are colonized. And as I've alluded to, asymptomatic colonization can still be spread. Screening typically occurs, as I mentioned, axilla and groin, but also there are current studies ongoing. They're looking at nares, oropharynx, rectal swabs to see if any of these have more of a correlation to clinical outcomes or predictors for invasive disease. Swabbing protocols are really different all over. I actually just saw an article this morning out of Texas that they have shown success with their swabbing protocol, identifying risk factors and using those risk factors to triage who is getting swabbed. There are a lot of different strategies out there, whether it's based on patients where they're coming from. If they're coming from a healthcare facility, I know at our institution, we talk about healthcare. We include healthcare abroad as being a potential risk factor for screening. And so I think it's really institution specific, facility specific for what your risk factors and epidemiology are. If you're not seeing any of this, then maybe that's not, we don't need to go jumping to swab everybody perhaps. So who should we be screening? I kind of alluded to just now different groups of patients, different risk factors. So those that have an epidemiological link to an infected or colonized patient. So patient that was sharing a room with another Candida auris positive individual, rooms shared by a healthcare worker as a nurse transferring Candida auris from room to room. Exposure after of medical equipment. This could be due to incomplete cleaning, especially as we talked about disinfectants not all working the same for this organism. We talk about prior healthcare facility exposure. I've mentioned this as well already. If there is suspected or confirmed Candida auris transmission, and notifying that through that transfer that colonization exists. We also include individuals coming from long-term care facilities or skilled nursing facilities as one of our items for screening to consider screening for colonization. And then in the inclusion of any risk factors for Candida auris. Does anybody here have a screening protocol or surveillance protocol? Okay. So in addition, or like I said, to these factors, these may be some considerations. I anticipate perhaps though that maybe rates are low at your facilities, that this hasn't been a huge issue yet. I will say the IDPH as well as the CDC have really great resources. So if this is becoming a problem, those are great places long after my talk today when you're like, what did she say? Great places to get some information. So all of these together are used for many of our infections. We're thinking multi-drug resistant organisms potentially. C. diff is another one. That comparison of spread or decontamination is often compared to, but all of these things play a contributing role with regards to infection prevention. So one of the questions that I had was, okay, so we have all these patients that are colonized. We're talking about risk of, who develops invasive disease and who doesn't. And so I really wanted to know is what can we do for these colonized patients, or how important is it that we do something for these colonized patients to prevent invasive disease? Colonization, for colonization, there's currently nothing approved or no recommendations in terms of decolonizing a patient. And so since we don't have that as an option at this time, we got to think about what comes next. And so this study, again, done in addition to one of our pharmacy fellows, and presented as well as a poster at ECMID earlier this year. So this was additional as well, a retrospective chart review. And so we specifically looked at patients that entered our institution who underwent Candida auris groin or axilla screening over this time period. We looked at patients out through the end of October. So yes, a weakness that before I even go into this is that the patients that were screened on August 31st to the end of October, they really only had a couple month window that we followed them for, if that makes sense. But those from January, we have been able to follow them for 3+ years. We defined, or we excluded patients who had a previous positive screen for Candida auris or a prior infection. We know that patients who are infected will often be colonized for a very long time, if not forever. I've kind of alluded to some of our practices at UIC in terms of screening those coming from certain facilities, screening those who have foreign healthcare exposure, as well as some of these other risk factors. And that is largely driven by nursing at our institution. The primary outcome was percentage of patients with a positive culture for Candida auris after a positive screening for axilla or groin. So they tested positive as a colonizer, and then within some time frame developed disease or developed invasive infection. We also looked at those who specifically developed fungemia, and then what does this timeline look like? How long is it between a positive colonization swab and a positive culture? So over that time frame, we looked at 608 swab screenings. Of that, 7.83% were positive. So as I move forward, I'm going to be talking about that specific group of people. Additional exclusion factors resulted in 30 individuals for analysis. But keep in mind, this is a small portion of even all those we screened out of all those we didn't screen in our institution. So in the grand scheme of things, as I show you maybe some scary results, keep in mind that this is, from that small group. Baseline characteristics, nothing too shocking here, especially having just shown you our characteristics from our other study. I do want to point out that the majority of patients were screened for colonization within 1 day of hospital admission. And then I also want to point out that a majority of patients were presenting from a healthcare facility. And so in our study, we found that the development of a positive culture for Candida auris from any site after screening was 33.3%. This included non-sterile cultures. So this did include respiratory cultures, perhaps trach swabs, included urinary cultures. So keep that in mind. So of those 30 patients as well, 9 of them had a prior negative surveillance swab. So I thought this was interesting too, especially given this range of prior positive surveillance. So this means that there was a patient who tested negative for colonization and 4 days later tested positive for colonization. So what is causing that? Is it their stay in the hospital? Is it their exposure to other colonized patients at a facility? So multiple things to think about here. Of the 10 patients with positive Candida auris cultures, 8 of them presented from another healthcare facility. And our median time from surveillance screening to positive culture was 46 days. So again, think if we screen them on their admission, if they're still in the hospital a month and a half later, that is when we're starting to see, or when we have most patients who are developing positive cultures. This is similar to what I shared with you earlier in that, thinking about the risk factors, this perhaps does make some sense that these are individuals who are hospitalized for very prolonged periods of time, have invasive lines and other things. Finally, 5 out of the 10 patients were identified as having Candida auris fungemia. So remember, that's out of the 30 patients who screened positive, to the 10 who had positive Candida auris cultures, to 5 that had fungemia. So yes, I think 50% is concerning, but I do want to put that in perspective to the cohort as a whole that was screened. These patients still had a similar median time to positive culture, just shy of 40 days. From this study, again, I mentioned that 5 of 30 who had positive colonization went on to develop Candida auris fungemia. I think this is concerning if this is a trend that, on larger studies is being seen. I think it's something that we need to continue to work towards potential decolonization strategies to combat this. Median time to develop Candida auris fungemia was a little less than 2 months. And then the majority of patients in our study and the majority who develop Candida auris fungemia are presenting from a healthcare facility of some kind. Again, the CDC really doesn't make any recommendations in terms of best practices for these patients. As I mentioned, there's limited to no data on successful decolonization practices. And so that just takes us back to some of those items that were on that infection prevention wheel as things that we can do. So we've discussed all of these different challenges today, and I think there's a very unique role in each of these factors in terms of how it contributes to Candida auris spread and development of invasive disease. And so what I want you to take away from this today is that diagnostic challenges can lead to misidentification or delayed identification. If there's concern for a Candida species that's not identified, this could be one of the things to think about. Due to high rates of resistance across the country, azoles should not be used for empiric treatment for Candida auris. And then infection prevention strategies are critical to reducing Candida auris across the country. With that, I think I left a few minutes for questions, but I also, again, recognize I'm what stands between you and dinner.
Thank you. Okay, any questions?
Yes.
So you mentioned the kind of long time period between admission and then development of a positive culture.
Right.
Do you have any information about like, the chief complaints on those admissions? I think you said they were.
Yeah, that's a great question. On this initial study, we did not. I think that's a great idea to help us determine. I think that, you know, the risk factors are pretty well established. But also, is there any, and this kind of derails from your question, I'm sorry, but it makes me think about, like, is there any reason to re-swab throughout their admission? You know, if they do develop these risk factors that we talked about, would there be some benefit to re-swabbing? Because you're right, it is a prolonged period of time. And is it something that's on front of mind if they're dealing with a whole different chief complaint? So yeah, I think looking at, you know, entry diagnosis could be an interesting thing with this study too. Yeah, thank you. Yes.
The slide that had all like pipeline.
Yes.
Where do you think they will come into play once they're approved or not approved?
Yeah, good question. Yeah, I think they will fall into that third box. So if you recall the treatment slide, we've got echinocandins followed by amphotericin, and then that's where we start talking about those investigational agents or combination therapy. Two parts to that, I think. One, as we have more data using them specifically in Candida auris, to really see their success, to find their place higher in therapy. I think we all, you know, may dislike amphotericin for many reasons. And so perhaps it could skip or bypass that even to being a recommendation. I think the other thing to think about too is that, you know, at least at our institution, and as I mentioned, IDPH and Jamie has sent out or has published that they are having similar resistance patterns in our state as a whole, that fortunately echinocandins are still successful before going to some of those newer agents. A weekly agent is always nice for people in the OPAT setting, so that could be a reason for that, for use there. I think that, you know, there are case reports of echinocandin resistance developing on therapy. So I think that may be another place to look at using some of our newer agents in the meantime.
I just wanted to check if the slides that we're seeing now is also in the flash drive.
They are not. And part of that, yeah. Part of that is because of the study data I shared. It's not published yet. And so that was one of the drivers. It is, it's posted as an abstract or published as an abstract and published as a poster. But we hope to continue kind of working on these projects. And so felt it might not be better to put all that out there just yet. The other part of it is just that these slides are being updated, you know, over days, just to kind of what's new. And so to have the most up-to-date information on a thumb drive that I had to turn in a couple weeks ago was not going to be up to date. Yes. Great question. So we use micafungin as our echinocandin of choice. And at our institution, we have looked that some cases are using standard 100 milligrams and others are using 150. We were unable to find any sort of connection or any sort of common thread as to why sometimes providers were selecting one over the other. We actually pulled that as a side project from the first one already and found no really meaningful outcomes. So we'll continue to look at that. But yeah, great question. It's something that we've been trying to figure out ourselves. Yes.
Hi, as you've identified, auris is a risk factor for long-term care.
Yeah.
Has anyone thought about looking at why? I work in long-term.
Yeah, yeah.
In the IP, I
Yeah.
have patients who are, going to be on enhanced barrier for
Right,
forever.
right.
It's not a home-like thing.
Right.
The disinfectants are very expensive. I don't know how to treat them
Yeah.
forever. Again, it just, so
It's,
I appreciate, that, prevention and everything side and the acute care, but what about us?
yeah.
If we're sending them all to you.
Right.
And
No, I totally agree. And I think that some of these infection prevention measures do also apply to y'all. As you mentioned, though, some of them are challenges in both settings. In terms of efforts made for the long-term care or skilled nursing facilities and such, I think that it's a huge, huge target area. I do know in Chicago, there was a team that went and did swabs at one of the facilities to hopefully at least give us a little bit more information about what's going on. Jamie Jacobs and I have talked about this multiple times as well, and trying to get some more information to see even what are our next steps in prevention. It's definitely a challenge. Yes.
Yeah, I was just curious if you had any thoughts or opinions on like an incubation period in Candida auris, like in the context of case investigation and trying to narrow down like which facility
Yeah.
may have acquired it. I know that's a hard one.
Yeah, and I to be honest, I don't have an answer for you. It may exist, but not that I'm aware of. Yeah. Sorry.
Well, I'm sorry, I came in a little late.
No, you're all right.
Was there any particular, correct me if I'm wrong, but was there a reason why you just looked at male patients and not female patients? I thought I saw.
We did.
Oh.
I think it was about 50% in both the first study I shared and the second study I shared.
Okay,
Yep.
that's it.
If I did, I apologize. So in this study, 19 out of 30.
Okay.
Yep.
Thank you.
Yes,
I have a lot of questions.
that's okay.
So in the first study,
Uh-huh.
showed the isolates that were resistant to fall,
Mhm.
like 8%.
Yeah, 2.
What was the main reason why you didn't want to de-escalate to almost near resistant? And then
Yeah. To be honest with you, I think part of it was unfamiliarity. We're being informed that across the country, it's 90%. So for us to have we have two isolates that say they're fluconazole susceptible, I anticipate there was some hesitancy, especially because those were fungemia. And so I think that, people played the better safe than sorry is my anticipation, reading between the lines in the notes from the physicians. But I think that when we start to talk about maybe some of the non-sterile sites, or, well, we're not treating those now, but in the past, when those were even being treated, there was more de-escalation to fluconazole that I saw. I think that there is probably a time and a place for it, given that, we don't have information in terms of, the resistance pattern in Illinois is so different. And so I kind of think until we have more understanding of that, I think we're going to continue to be hesitant to de-escalate. I say we as if I don't work on the inpatient side anymore, but I think that is what I anticipate would be a concern. Obviously, to put on our stewardship hat, the faster we can de-escalate, perhaps the better.
as a follow-up, what was the duration
Yeah, I would have to look back, but I believe, don't quote me on this, I believe it was somewhere in the 2 to 3 week range. Yeah, I think going kind of off of candidiasis guidelines, but also looking at clear cultures. Yes.
So, our patient had a urine culture.
Mm-hmm.
He had bacteria which needed to be treated with
Okay.
antibiotics. But at the same time, there was like 10,000 to 15,000 colonies of Candida auris as well. So our doctor prescribed 2 kinds of antibiotics
Mm-hmm.
and didn't see the need for an antifungal. I wasn't in a position to really know RN infection preventionist.
Awesome.
I had to go to the ID, and she said, well, that might probably be enough. That's what I need. So is that enough?
So that's so couple things that stood out from what you said. They had infection, or they had signs and symptoms of infection. And so yes, we're treating the bacteria, which could be the sole cause. Do we know if they've had prior colonization with Candida auris, or if they've ever had that identified before? So the guidance again from the CDC is that if it's non-sterile without signs and symptoms, they would not recommend it. That being said, in this case, I think it really muddies the water in terms of, is that contributing to their signs and symptoms? And I think that is part of our job as clinicians to make that decision. Again, I think back to one of the studies that tried to put together an algorithm for urinary or Candida auris developed in the urinary tract, and tried to, make a checklist of like, yes, no, right, on whether or not we should treat. That was before the recommendation not to treat non-sterile without signs and symptoms. But even their comments were to just evaluate the risk factors of missing Candida auris, versus over treating or treating unnecessarily. Worst answer, case by case, right? But I think in that situation, I think there's reason for both depending on the patient. Yes.
So I know there's been, a lot of, some of the typical, local transmission with, floors, improper hand hygiene and adequate environmental cleaning and disinfection. You may not know this, but do you know if there's any research that's showing if there's any links to overprescribing antimicrobials and floors?
Yes, there is. For both individuals are at higher risk if they have received antimicrobials or antifungals. I have not seen in any literature a specific timeline, if they got 10 days a month ago versus, those kind of things. But there is, yes, data suggesting that both antibacterials and antifungals increase the risk, especially with long-term use, increase the risk for Candida auris, as well as individuals who have had multi-drug resistant organisms in the past. So again, exposure to.
For that, was the patient is all treatment and surgery of that was that see if they had been previously overprescribed antimicrobial, or if they had used
We did not, I don't believe in this study, look at specifically patients, number of days of antibiotics in 30 days or something like that. We did not specifically look at that. I don't know off the top of my head. I don't think we included history of MDROs either. We did just talk about, or we did include chronic conditions, but nothing beyond that. Yep. No, you're good.
Based on the site of infection.
Yeah, I knew this was coming. Yeah. Yeah, absolutely. Yes, and obviously, thinking about urinary penetration is the big one. So yes, and that's too where I do believe there are some literature. It might just be a case report of making that switch then to fluconazole in someone who is susceptible for something like that.
Or referring to the UTI, like.
Yeah.
figure out.
Yep.
If somebody has an active infection and you treated it and thought, they had no more symptoms, do you just err on the side of that they're colonized? And so like in the long-term care, we would go ahead and, do a cancer process or whatever it is to do, or should we swab them to find out?
So yes, so we can make the assumption that they are colonized, and that will remain for a long period of time, if not forever. So yeah, I would continue those precautions. I will point out, and I know, perhaps I didn't target some of the long-term care questions, but they do have specific guidance through the CDC specific to long-term care. And they include things like that in terms of precautions and swabbing and that sort of thing.
From the public health perspective with that question, so we generally recommend someone who has infection, like you said, that they're now colonized.
Right.
And then also kind of like once someone has screen positive for infection, that that's just indefinite. Even when studies have been done in long-term care with colonization, fortunately, because of those long-term care, it just has a tendency to like pop up again.
Thanks for sharing. Yeah. As someone who has some of that long-term experience, I appreciate it.
Any other questions?
Sure.
Some hospitals will have some state relating or potential devices or the ICU. Have you noticed any difference between Candida auris, where on the state relating and those they test positive on screening or clinical culture more often than ICU?
Yeah, we have not looked at that. And so I really cannot comment in terms of what we've seen at our institution. We have not explored that data. Yes. Thank you. You could have given this. No, I appreciate it. I really do. I appreciate your long-term care perspective. Absolutely.
Any other questions? We will wrap up from this group, so any other questions?
I'll turn it back over to you now.
Okay, well, thank you everyone for attending. Now, before you leave, I'll say up front, my teammate Sarah's in the back. These are the instructions for getting your certificate. She'll email them also, but it's 2 sheets, so be sure Sarah or I give you the 2 sheets. So take these